And is my screen visible?
Yes, yes, it's visible. You can just slideshow. Do it slideshow.
Yeah, yeah, just going on to that. So thank you, Anaga, for the biggest compliment. And also, just one moment, please. Why it's not starting? Just one moment, I can't get to my slideshow.
Yeah, bottom right.
Yeah, yeah. Just taking too long. So I would like to thank the organizers, the AIOS team, the fantastic team that we have for giving me this opportunity here. And Anaga, thank you for the very kind introduction. Smile began in 2006 and it's really going strong even after more than a decade. So I would like to just go on to uh, say that why is Smile there and why is it going to still stay? I'm a consultant for Carl Zeiss. SMILE stands for small incision lenticule extraction. It's a new paradigm for performing refractive surgery. And as we know, it involves cutting of a lenticule within the cornea using only the femtosecond laser, and then subsequently removing that lenticule from the cornea using a very small incision. The dimensions and the shape of the lenticule confers to the refractive error to be corrected. And it was in 2006 that Professors Secundo and Bloom performed the first 250 eyes in their respective clinics. They showed that the procedure was feasible, was accurate, but that the visual recovery was too slow to compete with LASIK. We got the baton at the Center for Sight New Vision Laser Center in August 2008, and we have been able to treat quite a few patients and have happy outcomes. So this is the timeline that we're looking at. It is a procedure which is almost 15 years old now. And it also has US FDA approval in 2016. By 2018, more than 1 million procedures were done in the world. And why is it so? Even though excimer laser does fantastically well, and LASIK has also evolved as a very safe procedure, we still find a niche and a place for a procedure like SMILE. And that's because of the rare but the troubling flap related issues that Dr. Namrata so nicely pointed out. If it for you, it may be like 1 in 1,000 eyes that person had a complication. But for the person, it's 1 out of 1, and it's 100% for him. And therefore, whatever we can do in terms of safety and reliability and predictability goes a long way, especially in refractive surgery where we are working on normal eyes. So the remarkable aspects of SMILE are the predictability, accuracy, and stability. This is the aspect of SMILE which has changed very little since our very first study, even though many aspects of treatment have changed. The spot parameters, scanning pattern, higher frequencies, better surgical techniques, better know-how about the procedure itself. And you would find that more than 98% of all eyes are within plus or minus 0.5 of intended correction. And this is not just by one study. It's borne out by several studies across the world. And this is happening because corneal reshaping is happening here without ablation. We know that excimer laser acts by photoablation, where the intermolecular bonds between cells are broken. The photoablation rate increases linearly with fluence beyond a certain threshold, and it gets affected by many factors, including the depth of ablation, the corneal hydration, the humidity, the fumes in the area, and so on and so forth, which results in a scatter, especially for a very high treatment. SMILE uses cutting instead of ablation, which has very less influence of any of these factors. It's a binary process and not a linear one. So if it happens nicely and precisely, or it just doesn't happen. What about inflammation? Since you are making 2 passes of femtosecond laser, also 2 passes of Did you get more inflammation? That was one of the things that was really of concern. It was found that total amount of energy input into the eye with smile is even less than with femtoLASIK, which results in less inflammation and much higher stability of treatment. And this was very elegantly shown by a procedure, by a comparison study, which was done in Singapore, where they studied in rabbit's eye that smile at -3, -6, and -9 diopter, comparing it to LASIK, again at -3, -6, and -9 diopters. And they saw that in relax, the inflammation remained the same, whatever amount of diopters you treat, while in LASIK, the more treatment you do, more is the inflammation seen. And this also results in less stability of outcome. This is a comparison of one eye LASIK with femtoLASIK with the other eye smile. And you can see that the safety at different periods of times is showing the smile to be having a much better outcome as compared to LASIK. As regards stability, this is statistically significant difference where the stability of refraction is much higher after a smile treatment done for high myopia, more than 6 diopters as compared to femtoLASIK. And you can see it here that in the femtoLASIK eyes, there was a difference of about 0.6 diopters, while in the smile eye, it was 0.16 diopters. As regards the efficacy, the EDDRS letters were many more in SMILE group as compared to the femtoLASIK group. And mind you, this is the same patient. So we are talking about the same healing response, one eye femtoLASIK done, the other eye SMILE done. And therefore, it's a head-on comparison, and therefore it goes a long way to deduct things. As regards induction of aberrations, in excimer laser, you are concerned with these aberrations because they suffer from peripheral fluence loss. This does not happen in SMILE, and therefore SMILE has to be considered as a different procedure than LASIK, because I see many times the people argue that in SMILE, you are not doing a wavefront customization, but what you're getting is less induction of aberration in the first place. Therefore, because you are cutting out a lenticule with keeping the prolicity of the cornea in mind, it was seen by us and it was also corroborated by many other studies from the world that the induced aberrations are much less than what you would have with femtoLASIK. This is from the same group of people in whom we treated in 25 patients, a very high myopic group, where we did one eye SMILE, the other eye femtoLASIK, and you can see the point spread function. And it's quite evident that the SMILE eye is doing better. So was the image simulation comparison, where you can see the SMILE eye, which is the left eye, shows much better image simulation as compared to the femtoLASIK eye. And this is also because the optical zone that you get is a true zone and not having a peripheral vision losses, peripheral losses in energy. And therefore, you would have a much less aberrated cornea as well as a much better profile as compared to femtoLASIK. Data shows remarkable efficacy in terms of predictability, efficacy, and so we are now studying 10 years data, and we have found any changes over 5 years are in the direction of higher efficacy and predictability. And so truly it is a paradigm shift in refractive surgery. What about the surgical ease? It's a one laser solution, so there is no need to move station from one laser to another as in femtoLASIK, and therefore you would require less to do the same procedure. You would also need a slightly higher learning curve, but as compared to PRK, but you would find that it's a very, very gratifying surgery. It's much easy surgically than LASIK, but PRK, of course, scores in terms of, say, a much simpler procedure to be done. As regards biomechanics and ectasia, there are mathematical models which suggest that SMILE should have a better biomechanical profile because it spares the most anterior part of the cornea, both relative to LASIK and PRK. Yet, a few cases of ectasia have been reported after SMILE, and therefore, we need to be careful and follow whatever we know and not really venture into those corneas where we have a doubt about. Even doing SMILE in those corneas can be hazardous. As regards dry eyes, there are numerous studies published which demonstrate a clear advantage of SMILE over LASIK for post-operative dry eyes. And it has been found that the tear osmolarity is also better as compared to LASIK. And therefore, this is again a very important aspect of SMILE, which which we cannot ignore. Other advantages are that there is no flap, so there is no flap related issue, less dry eyes, better patient workflow, and it's much easier sell to the patients who want a flap free, blade free, and a truly laser procedure. The coming advances are that there are going to be newer lasers from more manufacturers. Maybe they would take into account the cyclotorsion portion. Maybe there would be a more well-defined ways in doing it, where we would have less chance of suction losses. Hyperopic treatments, presbyopic treatments are right around the corner. Cyclotorsional treatments, though we have overcome that difficulty by marking the cornea and just turning our cone in a way where you would have the cyclotorsional adjustment. But still, if we have an automatic one, it would definitely be more welcome. And if we have faster lasers with almost free floating lenticles, that would also be an investment. So in conclusion, it's a remarkable technique showing remarkable stability, predictability, and safety even over a period of 10 years. And it's definitely likely to be a tech choice for refractive surgery in the coming decade. The excimer laser still may be needed right now for hyperopia, retreatments, and customized treatments. Thank you.